Welcome to Talk Ottawa. We're here at the Ottawa Hospital General Campus, and our guest is the CEO of the Ottawa Hospital, Dr. Jack Kitts. Welcome back to the show. Thanks for joining us.
Thanks for having me, Mark.
And thanks for welcoming us here to the General Campus. We're going to talk about the future of this facility and the future of the Civic Campus and much more about the Ottawa Hospital itself in just a few minutes. But let's start with some recent comments that you made about the state of healthcare in Canada. And you said it's not as good as Canadians think it is. What did you mean by that?
Well, I think if you look at a pan-Canadian view of healthcare, and a lot of people, Canadians are very proud of their healthcare system. And when you actually peel back the onions and look at it through a national lens, it's becoming increasingly important as to what geography you live in, what province you live in, and even within a province, what region you live in, as to whether you have access to a higher level of health care.
So where you live dictates how good the health care is that you receive.
It's increasing in Canada, and we know that in certain parts of different provinces, there's different coverage for medications and different access to other than hospital care. So it's important. It's also important to your socioeconomic status. 1 in 10 Canadians are unable to fill a drug prescription. And also how you're born. Aboriginal Canadians still do not have the same access and care that other Canadians have.
So part of it is actually a policy issue as well as a geographical one in terms of which jurisdictions provide which kind of coverage.
Yes, it's becoming more provincial, and the gap between provinces will widen unless there is a pan-Canadian approach to Canadian healthcare.
Is it also an urban versus a rural thing? Are you better off if you live in a city close to a big hospital?
Yeah, I think we can accept that, you know, the proximity to a big hospital that treats the most latest world-class care, but there is a way to improve access to that care whether you live in the urban or rural areas. So things in Ontario like the local health integration networks can capitalize on economies of scale and transportation to the best place quickly.
I want to talk about this mentality that we have that you've alluded to, though. We're proud of our healthcare system. I think for a lot of people it's important to express that pride because they're worried that if we don't talk about how proud we are and how fundamental our public healthcare system is to being Canadian, that we'll lose it somehow. But is there a risk in this halo effect that you're describing? Is there a risk in thinking that it's better than it really is?
Right. I think that it's a huge risk. And I think the challenge is that if you are in need of acute care, trauma, cancer, cardiac, stroke, you'll get world-class care. So in terms of our publicly funded system, it is publicly funded for acute hospital care and doctor care. You don't have to pay for that. Everything else, there seems to be a wait, access is an issue, and there's a co-payment, if not a full payment, for anything but hospital and doctor care.
But there is this mentality that you've alluded to that we're doing a great job with healthcare when in fact we're not. And I think organizations sometimes have a problem where they're doing a better job than people think they are. They don't get enough credit.
Right.
I think there are actually times where that applies to the Ottawa Hospital, and we can talk more about that in a moment. But our healthcare system has the opposite problem, and I worry that if we don't diagnose the problem with our healthcare system, if we don't recognize that it's not delivering the results that we think it is, that we won't fix those problems and it won't be a priority to address them.
Right, but you see, the high-profile healthcare is the acute hospital care, and we do world-class on that. But over the course of the last 10, 15 years, the healthcare system has changed in that we have a growing aging population that is living longer with chronic diseases. And so we need more out-of-hospital care, community care, long-term care, things like that, and we haven't shifted our focus. So hospital care is still excellent, and you have access to doctors, but patients living with chronic diseases, some recent surveys looking at their satisfaction with the healthcare system shows that less than 48% of them are satisfied with the healthcare system, whereas on the acute care side, satisfaction with hospitals are often over 85 and 90%.
And when you compare Canada in terms of value for money and in terms of quality of care to other countries, we don't actually measure up to the extent that Canadians think we do.
No, and one of the countries that we studied with the Health Council of Canada was the Netherlands, which has moved from a middle performer over the past several years to a high performer, a top performer. And what they have shown is that the investments in healthcare in their country, the majority of investments in healthcare in all countries go to hospitals, doctors, and drugs. But over the past several years, there's been a shift from hospitals and drugs to community care, and they've become a much higher performing system. So there may be something to that. Whereas in Canada, over the last 10 years of the health reform, the amount of money spent, the proportion of money on hospitals, doctors, and drugs has remained constant.
So are you saying that as the CEO of a big city hospital in Canada, you're saying the healthcare system in a way is devoting too much attention to hospitals and not enough to care that's out there in the community?
Right, and I'm not pointing my finger at anyone. I'm saying we as a whole, that the leaders in the system need to start talking like and behaving like a system and not the hospital versus the community or vice versa. It's got to be leaders in the system creating a better system, and money does need to flow where it's necessary.
You're not asking for your budget to be cut, though, but you are saying that how the resources are allocated and where some of the services are provided, that has to change.
Right. I'm not asking for my budget to be cut, but I am suggesting that we need to step back and look at where the true needs of the system are, where we can create efficiencies in the current status, and reallocate the money as appropriate, meeting the needs of the population. I don't think we're anywhere near perfect on that.
Can you give us an example? What's something that they're doing in the Netherlands that we could be doing here that would give people better care and more value for money?
Well, recently, right here in Ottawa, there was an identified need for more palliative care beds, more hospice beds in the community. We have too many patients in palliative care in our acute care hospital. So working with the local health integration network, the CCAC, and the hospice community, we managed to support the creation of the new hospice beds in the community by taking $400,000 from our budget, transferring it to the hospice, and having at least 4 or 5 less patients dying in our hospital in palliative care. That's the way we need to look at the future.
So that's money actually coming out of the Ottawa Hospital's budget and going to serve a purpose somewhere else where it effectively does mean your budget is being cut, but you're getting the more value for money by having that money spent
right.
elsewhere.
The money would fund 4 beds in the Ottawa Hospital. If we transfer that money to the hospice, it funds 8 beds. So there's a net improvement for the whole system.
Our guest is Dr. Jack Kitts, the CEO of the Ottawa Hospital, and we'll be right back on Talk Ottawa. Welcome back to Talk Ottawa. We're here at the general campus of the Ottawa Hospital with the CEO of the hospital, Dr. Jack Kitts. And let's talk about some things that are happening right here at the hospital. I wanted to start by getting an update on the other campus, the Civic Campus, because there's been a lot of talk about the future of that location and how either a major overhaul is needed or perhaps even a new building.
Right. So I think most people know that the Civic was built in 1922, so in 2022 it'll be 100 years old. It's been renovated and renewed several times over the past many years, and our architects and facilities people will tell us that investing more money in trying to renovate that older building will cost much more money and not be really value for what we spend. So we need something new. The initial review said that if you were to build on site, it would take 20 plus years. You'd be literally building a new part with basically a plastic sheet between the construction workers and the patients, because you can't shut down the hospital to rebuild it. And it would be a much better investment to build on a greenfield site.
All right, so one of the sites that's been looked at is right across the street on the edge of the experimental farm.
Right.
Is that still a possibility?
We looked at 12 different sites in the geographic location that would be west of Fisher Avenue and north of Hunt Club Road. And based on the geography of the city and the layout of the city, across the street on Carling Avenue would be a very good location for the citizens of Ottawa, as would the corner of Hunt Club and Woodruff across from the Nepean Sportsplex. Both those have good access, meet a population, and so they're both being considered as potential sites.
And what's the process from here?
The process from here is to work with the governments and landowners, NCC, to determine what is feasible. And you know, obviously we'd like to nail down the site as soon as possible, and then work with governments to look at, hopefully in the not too distant future, before a 100-year anniversary,
sure,
get permission to build a new hospital.
Do you want to have it built before the 100th anniversary?
No, I think that would be really optimistic. I think we've done our last set of renovations within the last 5 years. Renovations last somewhere between 10 and 15 years, so I would suggest that you know, opening a new hospital sometime in 2025 or thereabouts would be reasonable. And
do you have a preference on location, you personally?
No, I think it probably would be easier if it was in proximity to cross the road, because this is a massive hospital, and for the citizens of Ottawa, we can't close one while we take a few days to move. So I think the move in itself and the proximity would be safer and better.
All right, we were talking before the break about the future of hospitals from the perspective of moving some services outside the hospital, mostly for economic reasons, for financial reasons, but there's also a trend towards providing care in other places, partly because it's safer. Hospitals with infections in particular are not always the safest environment for treatment and for care, and there have been issues related to hospital infections at the Ottawa Hospital in the past few years. Can you give us an update on that and how you're addressing it?
Well, for sure, if you're sick and require a hospital, the hospital is the best place to be. Hospitals are very good, and as I said, in Canada, acute care is world class. However, I did say that there's a trend to creating an elderly population with chronic diseases who are now too sick to be managed in the traditional primary care family doc's office, but really not sick enough to require acute care in a hospital. And so the hospitals and the community need to find a way to manage these patients, whether it's the hospitals in the home or day hospitals or polyclinics that Dr. Cushman used to refer to. We need to find a different way to manage those patients. So number one is to keep them out of hospital. When they're in hospital, obviously our focus is to keep them safe and make their patient experience as best as it can be. And we did have that issue with C. difficile outbreaks in the past year, and created SWAT teams which were designed to go onto a unit and declutter, disinfect, hand hygiene, and just basically all come down on the unit and do everything we can that we know would prevent C. difficile spread.
And is that working? Because there have been studies that show that there's a chronic problem with healthcare providers, that they're not good at washing their hands sometimes, even something as simple as that.
So our hand hygiene rates have risen, but you're absolutely right. Somehow the pendulum has swung from when I was a medical student, your hands were raw when you went home from washing, to it's optional. But the culture is shifting based on the need to protect the patients. But the real test is, are the C. difficile rates dropping? And the answer is yes, absolutely. They've dropped actually to our lowest levels in years. So I think that the combination of everything is working.
as we try to manage costs that some people would say are getting out of control in the healthcare system, I know that you've been focused on trying to find some solutions within the hospital, and you've engaged management and staff in that process, and there are some things that have come out of that process. One of them is in the area of scheduling surgeries.
Right.
Can you tell us a little bit about the changes you've made in that area?
Yeah, that's a really interesting one because, I mean, first of all, everybody in healthcare, and I would say everybody in the world knows that there are efficiencies and productivity to be gained in healthcare. There's no question that we can do better in terms of better quality at less cost, and that's what is being referred to as the value for money in healthcare. So everybody agrees we can do better on the quality side and we can do better on the cost side. So it wasn't difficult to motivate the team to say, if that's true, then we have to do things differently. We can't continue to do everything the same and expect to have better quality or less cost. And so what we've done is we've looked at the flow of surgical patients into the hospital. And this was hard for me to believe, but the data showed that the flow through the emergency department for surgery was highly predictable, whereas the flow of the surgeons bringing the patients in to the hospital on any given day was highly unpredictable. So our elective cases were unpredictable, our emergency cases were predictable. Right.
So in other words, if you had somebody arrive at the hospital with a particular set of symptoms, you could, in most cases, predict how long is it going to take before they see a doctor, how long is it going to take before they get treatment, before they get tests. But for somebody who actually had their surgery scheduled, on any given day, it could vary dramatically.
It's not that particular patient. I could probably tell you within one or two patients how many patients will come to the Ottawa hospital next Tuesday and require emergency surgery.
Right.
It's highly predictable, okay, by month, by day, by time of year. I can't tell you how many patients the surgeons will bring in electively next Tuesday. It varies from anywhere from 10 to 25 at the Civic Campus.
And why is that?
Because the surgeons book their patients based on the need, and there is no control over how many patients can be booked because different procedures take different times. You know, a vascular surgeon may do one case on next Tuesday, and the following Tuesday do 5 or 6 smaller cases. So the first thing we looked at was separating emergency from elective and reducing the variability so that we can actually predict and staff to the right amount. Just by smoothing out the variability and separating emergency, which bumps into elective, we don't bump in anymore. We have emergency rooms put aside. So separating emergency from elective, not mixing them, smoothing out the variability and smoothing it out over the course of 5 days has allowed us to provide the same volume of service at better quality, because now the patients are not all over the hospital, they're on a specific ward, and pull out beds, which allows us to save money. So it's same volume, better quality, and less cost just by smoothing out the variability.
So not more surgeries, but more efficient.
More efficient. So in the past, if hospitals became more efficient, they just did more.
Right.
Right? In the time of fiscal constraint, what you need to do is you need to be more efficient and not spend the money.
Our guest is Jack Kitts, the CEO of the Ottawa Hospital, and we'll be right back on Talk Ottawa. Welcome back to Talk Ottawa. We're here at the Ottawa Hospital, the General Campus, and our guest is the CEO of the hospital, Dr. Jack Kitts. And we've been talking about a lot of things as they pertain to today in the healthcare system, and the discussion really is framed around that for most of the time.
Right.
But at the same time, there is the future of healthcare in Canada that we need to look at, and it's not just a scary future from the perspective of how is it going to be sustainable and how is it going to be funded. I think it's also an exciting future from the perspective of how technology is changing healthcare and what some of the opportunities are. Give us some insight into what healthcare is going to look like 10 years from now, 20 years from now. What's about to change?
Well, I think there's going to be dramatic changes. I think the last 10 years has seen some really significant changes in the way we treat patients. Certainly terminal illnesses have become either chronic diseases or cured, and so I think this trend is going to continue, and the technology is really driving it. Technology and drugs, improvement in safety of drugs, efficacy of drugs. I think that the future is going to be more personalized medicine, where not only will we be able to diagnose the disease, we'll be able to determine through genetic studies which drugs will actually work, which drugs won't work, and which drugs will work and have the least side effects, so they'll be more specific. So I think personalized medicine is a really exciting part of the future, and it's in its rudimentary form now. It's here. It's not something that's going to come. There are now cancer patients who are receiving specific drugs for specific cancers based on their genetic makeup. So I think that's one. I think we will continue to improve on the technology. You look at our cyber knife today, and it's just the beginning. What used to be 12-hour craniotomies where you'd have your skull opened and tumors removed with dissection that damaged nerves and left you with facial paralysis are now 3 40-minute sessions as an outpatient to shrink and make a tumor in the middle of your brain disappear. And this can happen all over the body. We're using the robot to dissect what used to be called radical prostate dissections. They're now done through keyholes. So between technology, drugs, and personalized medicine, there's going to be radical changes. And I'm not worried about the future. I truly am optimistic and excited about what the potential is. In order for that to happen in Ottawa, you alluded to the fact that there's a lot of challenges in today's health system. And we do need to be focused on the access to care, the wait times. We do need to focus on quality, and we do need to worry about the value for money and the sustainability of today's system. But a hospital like the Ottawa Hospital also has to look beyond that and attract the talent that's going to be here and treat us in later life, our children, and even our grandchildren. So a big part of that is a hospital that is committed to research and innovation. The stars of today want to be on the leading edge of healthcare. They want to be the ones who discover the latest cure and the latest treatments and whatnot. So if we can continue to invest in technology, because it's coming out quicker than you can say it, continue to invest in our research enterprise and do research that's meaningful. We have a practice-changing research center, so as quickly as it's being discovered at the bench, we're bringing it into the bedside and then out to the community. And this is what
proximity is important for people who live in Ottawa. It's important to be close to that type of research, because that's being at the cutting edge could end up saving your life or the life of one of your family.
Being at the cutting edge means that you're creating that cure or that treatment, and the clinical trials are done first in your organization. So, what we do that is often not spoken about is when someone says, Mark, we have tried all the conventional therapy, it's not responding, there's nothing more we can do. However, we offer hope with the latest clinical trial or whatever the latest treatment might be. And it's not just that if we didn't discover it here, because we're in the business, we may be part of a multinational, multi-center trial. So patients in Ottawa will get access to the latest. I've heard from people say, well, I'll go down to MD Anderson or Sloan Kettering. When you're sick and have a chronic disease like cancer, and you need your family and you need to be in close proximity, I think it's wrong for anyone in Ottawa to think, I'll just go elsewhere. I think people of Ottawa should expect and get world-class care right here at home.
But they need to be part of building that world-class hospital, right?
Right.
That's part of the mix.
The latest technology, the investments in research, attracting the top talent is all based from the community. That's not what healthcare tax dollars go to. They go to running a hospital, and they go to today. If you're going to invest for tomorrow, we need a supporting community. And I must say, in my 10 years as CEO, I've never seen such an incredible supporting community as Ottawa.
Jack Kitts, thank you very much for your time.
Thank you.
Dr. Jack Kitts, the CEO of the Ottawa Hospital. That's all the time we have on Talk Ottawa. We'll see you again next time. Good night.